There can be symptoms of anemia, such as shortness of breath, lightheadedness, fatigue. And if it's very severe anemia that's untreated, this can be quite a strain for the cardiovascular system. Platelets function to stop bleeding through formation of a clot. When platelet numbers become limiting or low, this is termed thrombocytopenia and results in spontaneous bruising, small dots in the body called petechiae, or called, depending on their location, purpura, and an increased risk of bleeding, including spontaneous severe bleeding. And this is why we carefully monitor blood counts to decide if there's something needed to act upon. Okay. So in MDS, one or more of these cell types is low. And in addition, you may remember that I was saying that there are supposed to be limited numbers of these immature progenitor cells. So in a subset of MDS, abnormal immature cells can expand, as shown here. And in MDS with increased blasts, there's a natural tendency to progress to AML. In terms of types of MDS, in a small but important minority of MDS is called secondary, referring to the fact that it follows after exposure to certain types of chemotherapy or radiation. And this type of MDS evolves typically over 2 to 10 years, depending on the exact chemotherapy exposure or radiation therapy. And it's generally associated with adverse cytogenetic abnormalities, such as a complex karyotype or monosomies. MDS most often occurs in older individuals. And as shown on this graph here, the incidence is really quite rare in people who are under the age of 50, whereas the median age is over on this side of the graph, which is showing the 70 to 79-year-olds, the greater than 80-year-olds. And the median age at diagnosis is about 71 to 76 years of age. There's an estimated 20,000 new cases of MDS diagnosed in the US a year. And as I've been alluding to, the spectrum of disease is quite variable. So some MDS is quite indolent, whereas other forms of MDS are aggressive. And about a third of MDS can evolve to acute myeloid leukemia, which is the most aggressive manifestation of this disease. So over time, the field has learned that this clinical heterogeneity is also accompanied by genetic heterogeneity, genetic referring to genetic mutations. So we'll just take a moment to review what a genetic mutation means. It refers to DNA damage affecting one or more genes, as depicted here. And this happens with regularity in the body. There's DNA damage that is happening all the time, but the body has mechanisms to protect itself against DNA damage. There's DNA damage repair systems. There are programs by which the cell tells itself that it's irreparably damaged in a severe way, and so something called programmed cell death. And also the immune system surveys for abnormal cells to eliminate them. But sometimes cells with mutations persist, and if the mutation happens to hit an important gene or genes, then this can transform the cell into a cancerous cell. So there are two major types of mutations. They're called somatic mutations and germline mutations. Somatic mutations are gene mutations that are acquired during someone's lifetime, and they cannot be passed on, whereas germline mutations are inherited and can be passed down. So what do we know about germline variants in MDS? The traditional textbook teaching is that germline variants leading to MDS pertain to a very small minority of very young patients with MDS and are really not pertinent to older patients with MDS. In a recent recently published study, the authors undertook to establish the frequency of these pathogenic germline variants in patients who are 18 to 40 years of age to really establish, are they very, very rare, as has been kind of previously thought, or what is the exact frequency? And these patients had aplastic anemia, they had MDS, or they had AML that was preceded by MDS. And in this group with MDS or AML proceeding from MDS, they found that 19% of the patients possessed germline, these pathogenic or likely pathogenic germline variants. And I think you will agree that 19% is not so rare. The caveat is that this is very specialized testing that needs to be done to capture all the possible germline pathogenic or likely pathogenic variants. Another point worth making here is that in recent years, it's been established that there can be an inherited predisposition to MDS and AML that manifests later in life. That's what's being shown on this graph at the bottom here, is the age at onset for MDS or secondary AML. And so mutations in DDX41 can lead to an inherited predisposition to MDS or AML that is diagnosed later in life, like in the 60s or 70 year range. So turning now to acquired somatic genetic mutations. So recurrent mutations in genes that are called myeloid driver genes can drive the formation of MDS. So these mutations, this instruction manual, as it was previously described, it gets translated, it gets transcribed and then translated, meaning it often produces building blocks of cells. And this corrupted instruction manual can lead to abnormal building blocks of cells called proteins. Some of these are enzymes, and some of these mutant products could be the targets of therapies. And one example of this is mutant proteins called IDH1 and IDH2, that there are inhibitors too that are in use in AML, and these are under investigation in MDS as possible targeted therapies for MDS bearing these mutations. So genetic changes can be small, which are the ones that I was referring to in the previous slide, at the level of the building blocks of DNA called nucleotides, or they can be large. Chromosomes are bundles of DNA and genes. And this is an example of a karyotype, an example of having more chromosomes, something called trisomy. And so this is a form of mutation that's a large structural change. And this can also be detected by a different modality that Dr. Xu would have talked about called FISH, fluorescent in situ hybridization. So there are these two types of genetic changes, and these are important to characterizing MDS and capturing the fact that not all MDS is the same by any means. So in the last 10 years, using next generation sequencing technology, you don't have to kind of get cross-eyed and focused on the details of this graph, but it's meant to show that the recurrent mutations in MDS have been cataloged. And the specific mutations are important. They have prognostic significance, and the number of mutations also has prognostic significance. And here it is represented in a different way, showing that recurrent mutations, as the word recurrent implies, occur over and over again in a specific list of genes. And these genes are also associated with specific biologic processes. So there are genes like TET2, DNMT3A, ASXL1, what I was mentioning before, IDH1 and 2, that participate in something called epigenetic regulation and in epigenetic dysregulation in MDS. There are mutation in splicing factors, in genes that are involved in tyrosine kinase pathways, which are often involved in cell growth, proliferation, and survival, as well as in genes that encode transcription factors, which are very important to the cell identity, and also to genes, other genes like TP53 that don't fit neatly into one of these categories, but which in the case of TP53 is a master regulator of genomic integrity and potentially also of the normal immune response. So just to talk a little bit more about what epigenetics means, it refers to modifications of the DNA illustrated here, these little red dots decorations representing something called methylation of the DNA. And it also involves packaging of the DNA in different ways that causes different conformations. In MDS, there can be too many methylations of segments of the DNA that results in genes being abnormally turned off and in blocking maturation of cells. And so perhaps the major category of approved treatment for MDS, hypomethylating agents, refers to what is thought to be a major mechanism of action of these drugs, which is to decrease DNA methylation and allow these genes that were abnormally silenced to be activated again. Hypomethylating agents include azacitidine, which was approved in 2004, decitabine, which was approved in 2006, and an oral version of decitabine that we'll talk more about. Another area of very active research that Dr. Stahl referred to is that of the role of the immune system and immune dysregulation in the development of MDS. So abnormal immune and inflammatory pathways in the bone marrow niche play an important role in the development and also in the progression of MDS. And different kinds of immune cells are involved, not listed here, but they include T cells, B cells, macrophages, natural killer cells, secreted proteins that allow cells to talk to each other called cytokines, and also things like normal brakes on the immune system that normally keep the immune system from having an over-exuberant immune response that could lead to damage of the body as an autoimmune disease, but which tumor cells in MDS and in other cancers take advantage of to hide from the immune system. So turning now to the classification of MDS. The classification of MDS has evolved over time, along with our understanding of this disease. And there's no need to pay attention to the details of this, but it's just meant to show how our principal classification system, which is called the World Health Organization classification, has changed with its various iterations over time. And the newest version was published in 2022, and it's the 5th edition of this classification system. And there were important updates that are meant to integrate new biologic insights into MDS. In addition, in 2002, there was a parallel system that was published, which is called the International Consensus Classification System. And thus, we currently have 2 classification systems, which has led to many bone marrow reports becoming a bit longer and a bit more complicated. So again, there's a lot of detail in this slide, but we'll walk through a couple important points. So on each side, what's being compared is the previous version of the classification system with the 2 current classification systems, the WHO and the ICC. And these are subtypes of MDS, and these are additional subtypes of MDS. So in the 2022 WHO classification system, there were the addition of 2 new genetically defined subtypes of MDS, and this is common to both systems. They're called MDS with SF3B1 mutation and MDS with TP53 mutation. And this TP53 mutation in both cases refers to more than one hit to the gene because there are 2 copies of each gene. And the reason these are included is because of considerable evidence indicating that these are specific disease entities with specific prognoses. So very important to identify them. In the realm of MDS with increased blasts, the WHO recognizes two subtypes called increased blast 1 and increased blast 2, depending on how many blasts are present, whereas the ICC recognizes MDS with excess blasts, meaning 5 to 9% blasts in the bone marrow, and created this new entity called MDS AML, when the blasts are 10 to 19%, capturing the fact that this is a continuum of disease. It doesn't, we believe, really occur that from one day to the next, MDS changes to AML. And in fact, this is probably a more continuous process. And that's what this is meant to capture. Okay. Turning now to understanding the risk that's posed by the diagnosis of MDS. This was discussed before, but we will touch upon it again. Just like our classification systems, we have had what are called risk stratification systems that have been developed over the years. And the most recent standard that's found still as the criteria for selecting patients for clinical trials is the IPSS, the revised IPSS. And these systems have in common that they take into account what are called clinical variables, the degree of low blood counts called cytopenias, cytogenetics, which are these genetic changes, mutations, structural changes that I showed you examples of and pictures of before, as well as the burden of blasts, and it generates a score. And with the IPSS-R, there's 5 categories, and if you look down here or you look at the curves, there's quite a variation in survival, and there's quite a variation in the risk of progressing to leukemia. And so to have an operational way of using this, we separate these into 2 main categories, lower risk and higher risk. And we used it with the IPSS-R by us identifying a score of 3.5 and greater as higher risk MDS. And then we heard about the latest risk classification system just a little bit ago, which is called the IPSS-M, which finally integrates this new information about molecular genetic changes into the risk stratification and really enhances our ability to make predictions about MDS's impact on survival and on the risk of progression to leukemia. And here there are 6 categories, but the word intermediate is eliminated to make things more clear. So there's very low, low, and moderate low, and there's moderate high, high, and very high, with very dramatic differences in outcomes. Lower risk MDS has a median overall survival of 6.3 years. Higher risk has a median overall survival of 1.5 years. And as Dr. Stahl had mentioned, this system compared to IPSS-R moves people, 46% of patients, into a different category, which is very important because we use this to inform our management strategy. Turning now to the treatments for higher risk MDS. The only curative therapy for high risk MDS remains allogeneic stem cell transplant, which is outside the scope of this talk. But for those patients who are eligible for a transplant, this creates an imperative for an early referral for a transplant consultation. So we're now going to discuss other approved and investigational therapies that can be used either as standalone therapies in patients who are not eligible for transplant, or as what is called a bridge on the way to transplant for people in whom transplant may be a possibility. So returning to this drug called azacitidine that I mentioned was approved in 2004, this graph shows that compared to individuals who were treated with supportive care, intensive chemotherapy, or a low dose of a chemotherapy called cytarabine, the overall survival on average was 24.5 months in the azacitidine group versus 15 months. So a survival advantage was gained with the treatment of azacitidine, leading to its approval. However, additional analysis of the outcomes in patients treated with azacitidine or with a very similar drug called decitabine has found that when people are treated not on clinical trials, the outcomes are more limited. And the median overall survival can be more similar to 1 year, depicted in 2 different studies. In addition, for those individuals who progress after treatment with hypomethylating agents, the median overall survival is even more limited and on the order of less than 6 months. So really highlighting the fact that there's a great need to improve upon these treatments which are existing. So the latest member of this type of treatment to be approved is oral decitabine, decitabine cedazuridine. So this component of the medication permits it to be what's called orally bioavailable, meaning there are therapeutic amounts that reach the bloodstream and the body. And that's a great benefit because otherwise, if people are receiving azacitidine or decitabine, they're committed to 5 to 7 days in the clinic every month. And so having an oral drug is a great improvement for quality of life. So this oral decitabine was tested in 133 patients with MDS and CMML in the ASCERTAIN trial. And in 2021, there was an update on the results of this trial that reported a median overall survival of 31 months. So what are the efforts that are being done to improve upon a backbone of treatment with hypomethylating agents? So the concept of using venetoclax to inhibit BCL2 is one that you may have heard about. If you inhibit BCL2 with venetoclax, this releases a protein that's a pro-cell death protein that travels to a structure called the mitochondria, which then lowers the threshold for cell death, particularly in certain types of cancer cells. And so these are results from the phase 1b study of venetoclax added to azacitidine in people who had not received a prior treatment for MDS. And on the left, what you see depicted are high response rates in patients. And there was a reported short time to response of 0.9 months and a median duration of response of about a year. And on the right, similar to that mutational landscape graph that I had shown before, what's shown are different mutations associated with MDS and the percent of patients with the mutation and the responses. And this depicts the fact that there are responses in different genetic subsets of MDS. This combination was also trialed in a phase 1b study in patients who had relapsed refractory MDS. And as in the prior slide, what's depicted is that there were responses that were seen across different genetic subtypes of MDS, as well as responses specifically in transfusion needs, what's called a hematologic improvement, so decreased need for transfusions of red blood cells, platelets, or both. And so there's a randomized trial that compares the combination of azacitidine and venetoclax to treatment with just azacitidine, which is currently the standard of care. And this trial has completed accrual. It's called the Verona trial, and the results are eagerly awaited to see if they change and improve upon the existing standard of care. So what about other approaches to the treatment of MDS? You heard me mention that some MDS, a minority, has mutant IDH1 or IDH2. And there is an inhibitor for mutant IDH2 called enasidenib. And so this cartoon depicts clinical investigations in which enasidenib is added to azacitidine in patients with high-risk MDS that have never been treated, or enasidenib alone is used to treat patients who have been previously treated with for MDS. And you can see encouraging responses, such as an overall survival of 20 months in previously treated MDS group, or 26 months in the upfront group. In addition, there's a mutant IDH1 inhibitor, and there was an update within the past year on the results of treating patients with relapsed refractory MDS bearing mutant IDH1 with the IDH1 inhibitor called ivosidenib. And here there was an encouraging CR rate of 38.9%. And there was a median overall survival reported of 35.7 months, which is also encouraging. So now turning to a different approach for the treatment of MDS. So thus far, the treatments I've talked about are largely thought to work by acting on the abnormal MDS cell itself. But a different strategy is to think about the MDS cell within its bone marrow microenvironment. And that includes surrounding structural cells called stromal cells, but it also includes the immune cells that are present in the bone marrow. And this cartoon depicts that there is a normal process that's part of the immune response, which puts the brakes on the immune response. So I was talking about this before. So here we see cells of the immune system. Some of them are called T cells, and they're part of what's called the adaptive immune system, and some of them are macrophages, whose function is to eat abnormal or old cells. And in both cases, there's mechanisms to restrain and turn off that response so that it's not overly exuberant. And so these are called checkpoint inhibitors. And one strategy that is very exciting and promising is to use checkpoint inhibitors. And this has led to success in the treatment of various solid tumors and is actively being explored in MDS. So one of these inhibitory receptors is called TIM3, shown here. And there's a drug called sabatolimab that specifically targets TIM3. And it's thought to work by reinvigorating the immune system to attack the leukemia cell. And there's also evidence that it works in a dual fashion by targeting primitive leukemia or MDS cells called leukemia stem cells. So it may pack a double punch, so to speak. And this was studied in phase 1 trials and shown to be tolerable and have reasonable safety. And then it was studied in a phase 2 trial that was randomized and compared either decitabine or azacitidine plus sabatolimab or the hypomethylating agents plus placebo. And here the primary outcome of interest was either the complete remission rate or progression-free survival. And unfortunately, the primary endpoints were not statistically significant, which is what's shown here, despite trends in the right direction. But there was a late separation of the curves, suggesting that there might be some delayed onset benefit. And this is further suggested if you just focus on the duration of the complete remission. And if you look at these two bars, which are depicting months of CR, the addition of sabatolimab increases this red bar, and that which is depicting an increased duration of remission. And so this is not the primary endpoint. This is just suggestive, but it does give hints that there may be a subgroup of people who could benefit from the addition of sabatolimab. And in addition, there's data that suggests that this may be particularly true when there's a low disease state. So there's currently a phase 3 trial that's already accrued, and the results of that trial will be very interesting to see. So this is a cartoon depicting another important so-called checkpoint inhibitor. The most famous checkpoint inhibitors involved the adaptive immune system, which are these T cells primarily. But now there's another group of checkpoint inhibitors that target innate immune cells, which are the so-called first responders to infection and inflammation. And so you may have heard about this pathway, which is the CD47 SERP alpha signaling pathway, which is given a very clever name. CD47 is referred to as a don't eat me signal. So normal cells should not be consumed by the innate immune system. So they have these don't eat me signals so that the macrophage doesn't go after them. Abnormal cells can have, by contrast, an eat me signal. And in fact, some chemotherapy agents like azacitidine can increase the expression of the eat me signal. And so a very interesting strategy is to try and interfere with the don't eat me signal that tumor cells upregulate to escape innate immune surveillance, specifically macrophage immune surveillance, to try and restore this mechanism. And so the forerunner agent in disrupting this pathway was magrolimab, and combined with azacitidine, it was reported to be resulting in very promising responses, including in a very difficult to treat subtype of MDS, which I had mentioned, TP53 mutated MDS. But unfortunately, recently, the sponsor shut down the program in MDS after reviewing the phase 3 results, which underscores the importance of randomized trials to really determine whether or not there is a benefit to adding something on top of a backbone of hypomethylating agents. But all is not lost, and this box is a partial list of additional antagonists that are in clinical trials targeting the same pathway. And so this is a very active area of research. Finally, this table provides a selected list of some of the trials, the phase 3 trials, these very important randomized trials that compare the addition of investigational agents like venetoclax, like sabatolimab, on top of the approved backbone of hypomethylating agents, as well as one that I haven't mentioned, which is called tamibarotene, which functions in a completely different way as a retinoic acid receptor agonist. And the results of these randomized trials are expected in a couple of cases within the year. And so we'll see if it moves the needle. So in brief, MDS is separated into low risk and high risk MDS, as we've talked about in the last couple of hours. You can see that the approved arsenal to deal with low blood counts and low risk MDS continues to increase with new approvals. By contrast, on the right side for high risk MDS, not shown here, we do have allogeneic stem cell transplantation in selected individuals who are transplant eligible, but it remains kind of a lighter side of the graph. However, as we've discussed, there are many promising agents under investigation that give us the hope that sooner than later, our approved arsenal for the treatment of high-risk MDS will expand. And these are some of the trials that we've either had open or currently do have open, exploring some of these interesting strategies that I was speaking to you about before. So with that, I thank you for your attention, and I'd be happy to take any questions.
Great. Thank you so much. Very much. Thank you. Were there any questions in the room for the moment? Oh, go ahead.
I'll ask one. It's a little maybe off your topic, but is there any hope or way of using an immunological approach to low risk MDS, or is the genetic change just so massive that you can't use it?
Oh, no, I think that in both cases, the immune dysregulation is thought to be distinct, but that is an approach that's very much at the forefront of research and clinical investigation, including in low risk MDS. So I think you're right.
Thank you.
Anyone else at the moment for in the room? Okay, we have a question online, and the question is, with combination therapies for high-risk MDS, is it best to start combination therapies first?
That is an excellent question. Given the fact that there's a lot of work to be done based on our experience with hypomethylating agents, and I assume those are the combinations that are being inquired about. In someone where a trial seems like it's a good fit, there's things called eligibility criteria. We do encourage people to consider that as the treatment out of the gate.
Anyone in the room with a question? Okay, I'll keep going online. The question is, can you speak to the expanded access for luspatercept? What does it mean there's expanded access to luspatercept? And what is that?
So expanded access refers to programs through the companies that make the drugs that are different from the approved indication for the drug. And I'm not sure exactly what's being referred to in this question with the expanded access for luspatercept. So I'm not sure I can provide much more detail on that.
Anyone in the room? Next question online is, should all high-risk patients consider a transplant?
That's a very good question. And the short answer is that if it seems like the person could be eligible for transplant, and that actually can be kind of a tricky evaluation, then yes, anyone who's thought to even potentially be transplant eligible should be considered for transplant if they have higher risk MDS.
Any question in the room? Go ahead.
Can you briefly sketch out what makes you eligible for transplant?
Sure. So at more towards the beginning of when transplant was applied to MDS and AML, and still somewhat, I think, geographic, depending on the country. Age has been a major factor. And so approaching older ages, it was thought to be not an appropriate therapy because it can be very intensive. In practice in the US, an age about 75, older than 75, usually transplant is less considered unless the person is in exceptionally good health. So that's one dimension of thinking about whether someone's transplant eligible. Other factors that go into this are the details of someone's health besides the problem in the bone marrow. So is there, we refer to things like organ function. So is the heart healthy? Are the lungs healthy? Are the kidneys healthy? Because transplant is a procedure that requires fairly robust function of all those organs, so that to, have the possibility of a good outcome.
Any other questions? We have one online. Is it possible for low-risk MDS to evolve to high-risk MDS?
That's a great question. And the short answer is yes. Because even though we put MDS into categories, I think the MDS is unaware of that. And so it certainly can evolve and move from being low risk to being high risk, which is one of the reasons why there's a need for very regular follow-up and monitoring of low risk MDS. So it's one of the reasons why we monitor for changes in how people feel in their complaints. Are they developing heavy night sweats or fevers or weight loss? And we monitor the blood counts. Is there suddenly a change in blood counts? Are all of the blood counts headed down? And very importantly, are there immature cells that we can detect in the circulation, for example, when we do those blood counts and quantify the subtypes of white blood cells? Are there increased immature white blood cells, which are not supposed to be normally in the circulation? And all those things could potentially herald the evolution of low-risk MDS into higher risk MDS. And sometimes we don't know, and we can only fully establish that by perhaps doing a bone marrow biopsy to see the status of immature cells in the bone marrow. Other things that can tell us that MDS is changing is if we repeat the testing for those genetic characteristics of MDS. And we may find that there are new mutations which indicate that the MDS is changing. And sometimes we use a word evolving. And that can be linked to a change in the nature of the MDS. But occasionally it also suggests maybe a clinical trial or a clinical opportunity.
Any questions? No? Okay. Well, keep going online. Is there, for this patient, it says, I've been using Vidasa and it seems like it's not working as effective anymore. Is there any possibility of using Dacogen, or are they the same?
So there are some publications that they're not identical and that they work differently. And so there is some possibility that there could be a different response to decitabine, but generally, if there's the option, we like to change the treatment approach a little more substantially than just switching from azacitidine to decitabine if there's an option. So again, if a clinical trial could be an option, that would be preferable, for example.
Thank you. Any questions in the room? Another question is, this patient looks like they've been diagnosed with hypoplastic MDS, and they would like to know why is ATG suggested for this and not standard MDS therapy?
So hypoplastic MDS seems to be different in terms of the process that leads to this type of MDS. And it's part of our understanding is that the immune system is attacking the bone marrow and leading to hypoplastic, which means low cell numbers in the bone marrow, so leading to hypoplastic MDS. And ATG, or anti-thymocyte globulin, thymocytes is another word for T cells. And so ATG is meant to target the immune system. It's immune suppression to relieve that process as a means of treating hypoplastic MDS. And there's a recent publication that further suggests that hypoplastic MDS is different from other MDS. MDS is usually a process characterized by too many cells in the bone marrow, but because they're abnormal, they don't produce normal numbers of circulating cells. So there's a recent publication dedicated to these types of mutations that I was talking about that are germline mutations, showing that there are specific germline mutations in hypocellular MDS. But basically, to go back to the question, ATG can be recommended because it's a form of immunosuppressive therapy in a disease that's thought to be driven by the immune system.
Thank you. Were there any other questions in the room? Okay, well, that's all of our questions online. So thank you so much, Dr. Mendez, for sharing your time today.